Welcome to our webinar. Today's topic is AACE Advancing Immunization, Billing and Coding for Vaccination-Related Service for Patients with Diabetes. My name is Dr. Ricardo Correa. I am a Program Director for the Endocrine Fellowship at the Cleveland Clinic and also the Director for Health Equity and Inclusive Initiative there. I also have another hat where I work as the Program Director for a Health Equity Fellowship at the Creighton School of Medicine in Phoenix, Arizona. I have been editor and peer review of multiple journals. I have conducted some research, and I have more than 100 publications in high impact journals. I am here today with Cindy Hughes. Cindy is a certified professional coder and consulting editor for medical coding publication, including the AAP Pediatric Coding Newsletter and annual updates for coding for pediatrics. Cindy is also contributing editor to the American Academy of Family Physicians Family Practice Management magazine. So why AACE producing this Q&R and focusing on vaccination for patients with diabetes? Because our patients with diabetes need them. Infection can make it harder to manage diabetes. For example, we know that some illnesses like influenza or the flu can raise blood sugar to dangerous high levels. Even when diabetes is well managed, infection can be harder to fight. This means that persons with diabetes are at risk of more serious illness and complication. According to the Center of Control Disease, people with diabetes have higher rates of hepatitis B in their life compared with the rest of the population. People with diabetes are at increased risk for death from pneumonia. Persons with diabetes have 3 more times risk of being hospitalized due to COVID-19 and have worse outcome. Immunization provides the best protection against vaccine-related preventable disease. Vaccination can help keep family, friends, and community stay healthy. Why talk about coding for vaccine services? We know that adult vaccination rates are extremely low. Most adults are not aware that they need vaccines. A recommendation from a trusted healthcare professional, particularly a physician, is a strong predictor of whether patients get vaccinated or not. There are many missed opportunities for vaccination because many healthcare professionals are not routinely assessing vaccination status. So knowing about coding options can help us improve our patient vaccination coverage, especially patients that suffer diabetes. Our learning objectives for today's webinar is 1, to identify the codes for service that can be used for vaccines counseling in different circumstances, recognize opportunities for including vaccine counseling in an endocrinology practice, and use of AACE resources to support vaccines counseling and coding. The CDC standard for adult immunization practice provide a great framework to help endocrinologists and all healthcare providers work to improve vaccine coverage for our patients with diabetes. The CDC standard for adult immunization practice recommend 1, to assess immunization status of all your patients at every clinical encounter. 2, to strongly recommend vaccines that patient needs. 3, to administer or refer your patient to a vaccination provider. And 4, to document vaccines received by your patients. The CDC standard provide a nice framework for us to think about our coding options for vaccination-related services.
So now I want to switch gears and talk about some options for assessing, recommending, and referring patients for the recommended vaccines. We'll look at how obtaining that history, assessing their current immunization status, counseling and educating the patient and recommending those vaccines, and then referring the patient can contribute to different evaluation and management services, and we'll focus on documenting each service appropriately. We do need to focus on documentation, although the main purpose is always clinical follow-up, making sure that the next physician or other provider that looks at that patient's record has the information to allow them to continue with the course of care that you've started. But it also supports your coding and billing. And that is something that payers really are more aggressively looking at. So when you are using the framework from the CDC standard for adult immunization practices, those elements of work, that assessment of the patient's vaccine status, can contribute to your level of E&M service. The data reviewed and analyzed is part of medical decision-making. If you're reviewing an external record, like a state immunization registry or another physician's records, that contributes to your data to be reviewed and analyzed. It's also important to recognize that any extra time you spend on the date of the visit also can contribute to your level of service. And we'll talk in more detail about how that is put into place.
Cindy, I have one question here. So, for example, if I have a documentation of a patient that wants to get a vaccine and I just write all the things that I counseling that I give, can I add this, add a code on counseling vaccine without administration to the visit?
You can include that time in the time of your visit. And it, like I said, if you've also looked at some records or you spend some time after the visit arranging for a referral to go get those vaccines, putting in orders or anything, then that too contributes to your level of service.
Thank you.
So let's look now at some different evaluation and management services that might include that vaccine counseling. Of course, to address diabetes is typically probably either a consultation or an office visit. So we'll look at those. There's another service that I want to look at called principal care management. Hopefully you're familiar, but it is relatively a new service, and it's aimed at helping the patient between physician visits and could include either work directly performed by a physician or other qualified healthcare professional, or it could be time spent by clinical staff. So it's a good option to consider. And we'll look briefly at the preventive counseling, where the focus of that service is strictly to help the patient reduce their healthcare risk, their risk related to their diabetes. Office evaluation and management and consultation services are selected based on one of two methods. As I've mentioned, you might use medical decision-making, and that's probably common for your shorter visits that are only, say, 20 to 30 minutes of time. When you're selecting based on medical decision-making, you use two of three elements of medical decision-making. There's the complex number and complexity of problems addressed, the amount and complexity of data to be reviewed and analyzed, and then the risk associated with your management of that patient condition on that date, such as prescription drug management. Another option is time-based code selection, and this represents all of your time on the date of the visit directed to the individual patient. That can be time looking at records before the visit, time during the visit with the patient, and time after the visit, documenting the service, entering orders, conferring with other physicians, or maybe addressing a follow-up phone call from the patient. All of that can contribute to the time on the date of service. What doesn't contribute is the time spent by your clinical staff. So I'll ask Dr. Correa to introduce our first case.
Thank you so much, Cindy, for that introduction. And I think that we are going to our exciting part, that is the cases. So the first case is an established patient presented for follow-up of diabetes type 1. 20 minutes was spent with the patient in E&M, but patient not meet criteria for management goals. Pneumonia and influenza vaccines are due. 10 minutes recommending counseling and referring, and 10 minutes documenting all service provided on this day, including pre-chart review, including review of immunization status and post-documentation. So the documented total time on the date of the encounter was 40 minutes. Here we have a case that includes time spent in vaccines counseling in the time of an established patient office, visit follow-up with diabetes type 1. The time used in code selection is the time personally spent by the endocrinologist directed to the individual patient care on the date of the visit, including the review of the chart and visit documentation when performed on the same date. So how do we know if the total time or medical decision-making is better coding option?
Well, we'll look at the times on this slide. They represent the requirements for times for each of the different office visit, new patient, established patient, and the outpatient consultations. And with our 40 minutes documented total time by the physician in our case, that would support 99215. And again, this is supported in the documentation that 40 minutes were spent. I want to take a brief aside to say that if the patient required even longer, if you met 55 minutes of total time on the date of service, it would be possible to report prolonged service in addition to the 99215. Now, there's a caveat on that. If you have a health plan that is following Medicare policy, they'll instead require G2022 and have a higher time threshold for reporting prolonged service. And that's not something that you necessarily need to focus on, but rather your billing staff should be aware of and choose the appropriate time and codes for reporting. But let's look at what this case would look like reported based on medical decision-making. The problems addressed was one chronic condition that was not at goal, and so that's a moderate complexity problem. There was probably a moderate amount of data to be reviewed and analyzed, different test results, tests ordered, and perhaps an external record of the patient's immunization or other services they've received between visits. And then there's the risk of management with prescription drug management also being moderate. This would likely be a 99214 service. So we can see that the 99215 based on time would be beneficial when you're able to spend that amount of time with a patient. Importantly, whether you're reporting based on medical decision-making or on total time, your diagnosis code should reflect the complexity of the visit. Your E10 code for type 1 diabetes should include additional characters that indicate the status of the diabetes at this visit as being poorly controlled or inadequately controlled, perhaps representing manifestations that the patient is experiencing, and additional codes for those types of things like kidney disease. Then your long-term use of insulin code Z79.4. And finally, you can add a code when you provide immunization counseling, Z71.85. And this is useful in your practice also for kind of tracking how often you are providing that immunization counseling during visits.
Oh, thank you so much for going in detail on how we bill and code this this patient. And I think something that I usually find my personal experience is that using time visit is less click in the electronic medical record than we use medical decision making. So it's good to know that we can add other codes to also justify that time, because sometimes we cannot justify the time, but we add the immunization counseling and we document that there is an immunization counseling, then we can add the Z code there.
True.
So now let's transition to something that you mentioned at the beginning in your introduction about a different option, that is to include and report vaccine counseling in the course of a monthly care management service. Can you tell us about principal care management?
Yes, I'd be glad to. As Dr. Correa said, the principal care management is a monthly service reported based on time spent in a calendar month. There are certain requirements for providing this service. It's not for every patient every month, and not every practice will have the qualifications necessary to provide it. But if you can provide it, it is a wonderful benefit to the patient whose diabetes is not well controlled. It gives you a continuing connection with that patient between visits. To qualify, the patient must have one complex chronic condition, which is diabetes, expected to last at least 3 months, places them at significant risk of hospitalization or other health risk, requires frequent adjustments in their medication, and or management of the condition is unusually complex. Maybe they also have hypertension and cardiovascular disease that affect how you manage their diabetes. These things all help support the need for the principal care management. And these services are something that require documenting that the patient agrees to receive the service. That is a Medicare policy, but other plans may adopt it. It's a good idea to get the patient's agreement because they may have out-of-pocket cost, like it could be applied to their deductible or co-insurance. The practice requirements are listed out in your CPT, current procedural terminology manual, and there are about 7 of them, but I want to focus on just 3 that are maybe a little higher hurdle for some practices. The first being that you must make it possible for your patient receiving principal care management or their caregiver to contact you 24/7, regardless of the day or time. They need to be able to speak or somehow converse by patient portal or some method with one of the healthcare professionals in the practice when they have an urgent healthcare need. You must also use an electronic health record and be able to access that record when speaking with the patient and know what is going on with them currently. And all of the care team members, when your clinical staff are providing activities of principal care management, they must be integrated into your practice. They must be someone that you can supervise and direct, and not some third party with which you have no real connection. So what is principal care management? It is a set of activities that are focused on helping the patient know where they stand with their diabetes and where you want them to go and how they're going to get there. And the activities may include education. They may include a lot of reassessment and supporting the patient's adherence to the treatment plan that you develop. And they may also include things like addressing social determinants of health that are preventing the patient from following their plan or being a barrier somehow to the patient achieving an optimal control of diabetes. And the care plan is the key point of this service. It's where everything is focused. So we'll look a little closer at that. And you may see this called the plan of care or a care plan. Either way, it's a concise overview of the condition the patient has that you are managing, the status of that condition, where you want that condition to be, what your goals are, and what other factors complicate or help you care for this patient. So you would include quite a bit of patient detail, but yet it's rather concise format to, at a glance, look at where this patient is at. What you see on this slide are just copies from a plan of care that were developed by the Agency on Health Research and Quality. And that continues on this slide. This link to this resource will be in the webinar resources so that you can take a full look at this if you'd like to. It is part of a how-to guide to chronic care management. Chronic care management is a larger scope of principal care management, addressing all of the patient's healthcare needs and all of their conditions, taking responsibility for all of the patient's care. But this guide could easily be adapted for principal care management. Another thing I wanted to note about care plans or plans of care is that your EHR may include a template for documenting this plan, and it may also include templates for documenting the service. The care plan must be shared with the patient, and it's good to document that you've done that. When you create or revise the care plan, always share that with the patient. The codes for principal care management are based on time, and the time can be either totally time spent by a physician or other qualified healthcare professional, in which case 99424 is reported for the first 30 minutes. And if you have an additional full 30 minutes of service, 99425. When time includes clinical staff time, it can be a combination of physician and clinical staff, or it can be just clinical staff. The first 30 minutes is reported with 99426, and each additional 30 minutes reported with 99427. If you do not have 30 minutes of time in principal care management during a calendar month, you don't report it. And when the clinical staff are talking to a physician or other qualified healthcare professional, at the time of that discussion, each minute counts as 1 minute. It's not 1 minute for the clinical staff and 1 minute for the physician. So now I'll ask Dr. Correa to please give us another case.
Yeah, so it was really nice to know that each minute count, and it's not just the minute that you spend with, as a physician, with the patient, but every person in the healthcare workforce counts. So thank you so much for that. So now that we have discussed the requirement and activities of PCM, let's look at a case study. Here is a new patient is seen by an endocrinologist in the office for progressively worsening diabetes and poor medication adherence. The endocrinologist discussed PCM with the patient, and the patient agreed to receive the service. After the visit, a nurse developed a care plan documented based on the endocrinologist's assessment and plan follow for the patient. The care plan may be shared with the patient via patient portal or email or in person. The nurse scheduled regular follow-up conversation and include discussion of recommended vaccines in a conversation early in the month. Later in the same month, the nurse confirmed that the patient received immunization at the primary care physician office and documented this. Over the course of the month, the nurse spent 60 minutes providing education on diabetes management, encouraging the patient diet and medication therapy to be more adherent, updating the care plan and patient medical record, and other activities related to encourage better diabetes management. All these activities take place under the endocrinologist's general supervision. So now, can you tell us more about how we will be coding this?
Yes. So we have a couple of services provided in this case. We start with the new patient office visit for poorly controlled diabetes. That's likely a level 4 99204. And the diagnosis codes would support the status of the diabetes at that visit. along with the current use of insulin, which indicates that you're managing insulin. And then at the end of the month, based on the time accrued of 60 minutes, the physician would also report 99426 for that first 30 minutes and 99427 for the second 30 minutes. In conjunction with these codes, the same diabetes codes would be reported, but you would add the Z7185 for that vaccine counseling that took place during the visit. On this slide, I have included some relative value units, RVUs, and my purpose for doing that is not to show you what they'd be in your practice, but to give you a general idea from the National Medicare Physician Fee Schedule, how these services are valued. And you can kind of relate that you've got about half the value, a little bit less of the level 4 office visit in that first 30 minutes of clinical staff time, providing principal care management.
Thank you, Cindy, for this enlightening in PCM that not everybody has the knowledge. So now let's talk a little bit more about another option that is, you mentioned this too, about preventive medicine counseling. So can you tell us more about that one?
Yes, preventive medicine counseling is just what it sounds like. It is counseling specifically for preventive purposes. You want to help the patient reduce their healthcare risk. It's not focused on any illness. It is a service that must be provided by a physician, an endocrinologist, nurse practitioner, physician assistant, but not clinical staff. And it is something that can be provided on the same date as an office visit to address the patient's health problems like diabetes. It is reported based on time. The codes are 99401 to 99404. The time is approximate. So 99401 is described as approximately 15 minutes spent by a physician or other qualified healthcare professional face to the face with the patient providing this counseling. The CPT code set has a midpoint rule that applies to this code because there's no other time instruction. There's not a minimum amount of time otherwise set for reporting 99401. So the midpoint must be passed to report the code. That means that you must get 8 minutes of face-to-face time in counseling documented in order to report 99401. It can be anything from 8 to 23 minutes and be reported with 99401. At 24 minutes, you're going to move to 99402. If you're reporting a separate office visit, again, separately identifiable documentation showing that it was a significant visit to address a health problem, and append that modifier 25 to the code for that visit. We're not going to present a case study on this example because it has relatively limited utility. Currently, despite the need for vaccine counseling with all of the vaccine hesitancy that we've seen, many payers limit the payment for 99401 to specific preventive services such as contraception counseling or weight loss counseling in a patient who's obese and at risk for developing diabetes or other chronic healthcare conditions. But you can find an example in the AACE coding for vaccine-related service for patients with diabetes resource that's included in this with this webinar. Now I want to just highlight a few other areas where clinical staff or other members of your practice who are not physicians or other qualified healthcare professionals might contribute to vaccine counseling opportunities. If you have a certified diabetes educator in your practice, that diabetes self-management education and training curriculum probably includes a risk subject category, which will include counseling based on the standard for adult immunization practice. And so that is one opportunity to provide the counseling without taking up the time of an endocrinologist or other qualified healthcare professional. Not separately billable, but another opportunity for brief vaccine counseling, maybe just giving the patient one of the AACE handouts, is when your patient comes in for setting up continuous glucose monitoring, or when they return to have that monitor's data downloaded for the physician. Also, opportunities exist when you've seen a patient for an office visit and you ask the patient to come back and see a nurse or medical assistant for some kind of follow-up care, maybe some education or counseling. And that's another opportunity for those nurses and medical assistants to step in and help provide that counseling and those resources. As we kind of wind down our presentation, I want to again focus on documentation. In order to take advantage of the options to document based on time, you must document how you spent your time, give a brief overview of what that time was spent addressing, and then you must document the time appropriately. If you're reporting an office visit or consultation, you want your note to say, for that patient, my total time today was however many minutes. If you're documenting the preventive counseling, you want to say, I spent 15 minutes with this patient discussing vaccines that are recommended for them that they should seek and where they can find them. For principal care management, I would encourage having some kind of templates for documenting this service, hopefully in the electronic health record. And each activity should be documented along with the time spent, who performed the activity, their credentials, RN, medical assistant, whatever it may be. And of course, the date of service should be captured. We've given you several options where you might include vaccine counseling in your practice. Now, what we'd like to ask you to do is to determine how this applies to you. Is time-based reporting an option for you? Is it sometimes an option that you want to keep in your back pocket for those longer visits, for those visits that result in extra work after the visit? And for principal care management, can your staff find out which of your payers are covering that service? Because it is still relatively new, the payment is not a certainty. You'll want to look at payer policies and determine that you will be paid for the service if you report it. And what are you already doing that supports that service? What would you need to maybe add or change? And finally, for vaccine counseling that's already offered in your services, where is that and where might you add it?
So thank you so much, Cindy, for covering in detail all the coding part. I know that it's very difficult for practitioners to specify all of these kind of things, but it's always a good refresher looking at all of the things and where we can add some of the different codes. I think that's something that I get. It's like if the patient comes for just glucose download monitoring, a CGM monitoring, insulin pump monitoring, we can also add during that visit with the nurse or the CDE, add some counseling, and that can be added to the chart. So sometimes we focus just in the physician or provider visit, but we can use other healthcare workers also to help us in other parts, and probably that make easier and shorter the visit to the patient. If it comes for a dynamic testing, you can add that part if you order that. So thank you really for this overview. Now I just want to finish with revisiting again our learning objectives. We start with the objective of identifying codes for service that can be used for vaccine counseling in different circumstances. We cover that. recognize opportunity for including vaccine counseling in an endocrinology practice. And also we cover the use of AACE resources to support vaccine counseling and coding. Remember that Cindy mentioned that with this webinar, also you get another sheets that will help you with that. So these are the resources, tool and learning opportunities. For example, we have a tip sheet, a coding guide, and some cases, and also a pocket card, a poster, and a patient bingo card that you can give to your patient. So all of that, you can find it in the AACE webpage that is down here. We want to acknowledge that this presentation is provided by the American Association of Clinical Endocrinology through the grant specialty of the Specialty Society Advancing Adult Immunization, funded by the CDC and coordinated through the Council of Medical Specialties. And with this, this is the end of our webinar. Thank you so much for listening. Thank you so much for caring about patients with diabetes. And please continue doing vaccination counseling that will help our patients to suffer less side effects or adverse event. Thank you so much.